Thanks, Dr. Arnon Krongrad, for talking to the Op Report today about Surgeo. Please tell the audience what this is, what the model is that you've developed for surgical care.
The model is a logistics model. It recognizes that every patient wants three things: quality, convenience, and choice. When it comes to surgery, we believe that quality comes principally from the surgeon. And so as we seek to simplify access to quality care, we put a heavy emphasis on which surgeons to work with. We use a peer credentialing process. I can certainly get into it in great detail. Point is, once we find these qualified surgeons, we wrap their services in everything a customer might want. So for example, anesthesia, facility, implants, physical therapy, and so on. We take these uniformly defined choices of flat fee surgery packages led by peer credentialed surgeons, put them all on Surgeo.com, and invite the user, principally patients at this point, to do their shopping that way. And of course, we have offline support too.
Interesting. So I suspect that surgeons just hearing about this model for the first time would have concerns about accountability and follow-up care. Can you talk about the pre- and post-op surgeon-patient relationship?
The beauty of what's happening with Surgeo is that surgeons are asking exactly the right questions, like the one that you just asked. This is a surgeon-driven model. So, for example, when we first designed our first orthopedic program, a total knee replacement, we didn't have a urologist design that package. We had orthopedic joint replacement surgeons design them, and they included what they thought was critical to a quality outcome. Pre-op evaluation for sure, the surgery itself, post-operative care including 12 sessions of physical therapy, and so on. Carpal tunnel includes occupational therapy. Penile implant surgery includes post-operative visits and education in regards to how to work the implant. So the model takes into account the opinions of surgeons.
And a lot of the patients are traveling to locations for these packages. How are post-op complications and the physical therapy handled in that?
Every patient travels for surgery, and that's because nobody has surgery in his living room. So there's always some. Now, we don't seek to get patients to airports. That isn't the purpose of this thing. And we're not a travel agency. And so what we're trying to do is, once we identify highly qualified surgeons, is to bring in more of them and to distribute them geographically. So actually, for the convenience of the patient, including in a situation that you described, you're not dealing with any sort of complicated travel. For example, yesterday, one of our patients had surgery in Lake Elmo, Minnesota. It's a suburb of the Twin Cities. He lives in St. Paul. I think most of us would consider that to be a very reasonable distance. So it's possible, once you check off the quality criterion, which is something we're not prepared to compromise, then we expand the network. Look, fundamentally, choice is a critical element of health services delivery. You have to have quality, you have to have choice, and so we're all about expanding choice through the integration of more and more qualified surgeons.
Mm-hmm. And has getting liability insurance been difficult or no?
We're not providers, right? We're not delivering designated health services, okay? So we don't need malpractice insurance. Our surgeons do obviously have professional liability, much as you and I have professional liability when we touch a patient, but that's something that goes with the provision of services. It's true for the anesthesiologist, it's true for the facilities and so on. So that liability rests with them. We carry professional and general liability insurance for the work that we do, which is accommodating the logistics. We have cybersecurity insurance, but we're the logistics company.
I see. And if this model produces comparable outcomes and patient satisfaction at lower cost, what's going to prevent this from becoming the dominant model?
Nothing. The reality is that I actually think we're going to get better outcomes than average. I mean, if it compares to just the average surgeon, okay, the peer credentialing process really brings in some unbelievably accomplished and qualified surgeons. It's not just about peer credentialing. It's not just who do you like and who do you like to have dinner with. In other words, we ask other surgeons who've done these surgeries with you how you operate. We also look at other things that your peers may not know about. I'll give you an example. When we built one of our urologic reconstruction networks, which now has 18 surgeons distributed from New York City to Phoenix, those 18 surgeons have done a cumulative 22,000 of this one procedure. there was one malpractice payment in that entire set of 22,000 procedures of $2,500. In other words, it's an unbelievably clean and experienced surgical network. Now, those guys are driving these packages. What we're seeing in what has become a true surgery free market, where they are liberated to define their own costs, their own prices. First of all, is we're seeing an elimination of cross disparity from place to place. In other words, contrast this with an opaque model like a third-party payer model where we see 300, 400, 1,000% difference in the cost. We see a surgeon-driven surgical delivery model, A, delivering very high-quality care, B, addressing many of the things that are driving the payers, the employers, and the patients crazy in terms of the delivery of the system. And ultimately, because it helps to integrate excess capacity, including in facilities, I mean, that's something that we haven't gone into, it does actually overall lower cost while still satisfying all the participants, right? So do we think it can drive simplicity? Do we think it can drive savings overall while still keeping the participants happy? We do. It's not a zero-sum game. It's an optimization game. The back of the envelope calculation says that we can reduce the cost of surgery in the U.S. by 20% using this model.
Now, are there stakeholders in the existing model who are pushing back against this?
You know, that's one of the things we didn't know when we started. So far, we haven't felt any resistance. And what's interesting and gratifying, I would point to two things, actually. First of all, that surgeons get it. We're getting unsolicited applications from surgeons. Last night I got an inquiry from a surgeon who's very advanced at gastric reflux surgery, Nissens and Links and that sort of thing. Never heard of him, but his resume so far looks exquisite, right? So the surgeons are getting it, and they want to get in. What's interesting is that some of your, call them mainstream blue blood institutions, the large integrated health systems, also want to get in. So, for example, we now have the University of Utah Medical Center contracted under Surgeo, including the facility, anesthesia, and surgeon, Mount Sinai Medical Center in New York City. And so, if you like, we can get into why they would want to work with this. But you'd think that if anybody would push back, it would be these large organizations. And to the contrary, they want to get in.
Interesting. So what else can you tell us about Surgeo?
Sergio seeks to broaden the conversation. I think it's been perverted. The conversation's been perverted. In the United States of 2016, it seems that the only thing we talk about is money. Money is a means to an end. Healthcare is not about money. Healthcare is about living longer, feeling better, functioning better. I think that when you bring people who understand what it's like to take care of a patient into that conversation, it begins to modify that conversation. And so what I hope is that Surgeo will serve as a platform and as a catalyst for surgeons who, in my opinion, know more than anybody about surgery, to have a say and to help us move forward in a way that makes sense for everybody.
Great. Well, thanks for talking to the Op Report today. Nice to meet you, Dr. Krongrad. I hope we can talk some more soon.
Thanks, Chris.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.